that doesn't focus you in on a diagnosis opens up the possibilities. Okay, 1-to-1 until the VA interval starts prolonging, and finally it terminates with a V and no A. So let's just move on for a second. Wide QRS starts with a wide QRS followed by a P. So this particular wide QRS doesn't have a P wave in front of it. So now I have to come up with hypotheses and conclusions. What do I know? Well, what's that beat? Who's going to help me? A wide QRS not preceded by a P. Probably a PVC, yeah? If it were something else, you'd expect to see a P wave there. Okay. Followed by a P. And then what else do I see? I see a 1-to-1 AV relationship until the termination of the tachycardia. And I see that when the VA interval prolongs, the VV interval prolongs, right? This prolongs and it slows down. Well, what does that suggest? Again, I can't make a clear diagnosis here, but it suggests that VA conduction may be part of the circuit. It may be relevant to the tachycardia, because when the VA prolongs, the cycle length of tachycardia prolongs. So it suggests that that interval may be important. So now I've come up with a hypothesis that there is VA conduction, and that the VA conduction is actually part of the circuit. Okay, well that's interesting. And what else do I see? I see when I have VA block, when there's no A at the end, the tachycardia terminates. So it suggests that the atrium must also be in the circuit. So what tachycardia would typically start with a PVC and has both the atrium and the ventricle as part of the circuit? There's other pieces we can have in there. Anyone want to help me? So an accessory pathway mediated tachycardia would be the first thing you would think of. As VA conduction is important, both the A and the V are in the circuit. It's initiated by a PVC. You wouldn't expect to see that with AV nodal reentry or with atrial tachycardia. Very interesting. And the VA is not only in the circuit, but in this particular case, the VA is decremental, because the VA gradually prolongs, and then we have VA block and the tachycardia terminates. So the VA conduction must be over a decremental pathway. Well, what's the first decremental pathway you would usually think of? The AV node. So isn't that interesting? It's not proof. You can have a decremental accessory pathway, but in this particular case, it suggests that the AV node might be the retrograde part of the circuit. Interesting. But I have a wide QRS tachycardia, knowing that there's no pre-excitation on the baseline sinus rhythm. So I now have to explain the wide QRS. Well, this happens to be a right atriofascicular accessory pathway with conduction down this funny accessory pathway and up the AV node. I don't expect anyone to look at this and say, oh yeah, that has to be that. All I'm showing you is that by making simple observations and descriptions, you can sometimes come up with exceedingly complex ECGs. This is a very complex ECG. I show this to electrophysiologists who, like myself, have been practicing nothing but electrophysiology for more than 30 years, and we all stumble on it. But the point is, if you have a system and you take a systematic approach, you can make even difficult ECGs fun, interesting, and you might actually get it right. Okay, so let's do another one. I promised you I was going to only do hard ones, no easy ones. I've done that purposely. So let's have a look at this. So what do we see? Again, we take a look from the back. We don't take our look from the front. We don't look for the trees, we look for the forest. So what do I see? Well, I see 2 sinus beats to begin with, and I see a tachycardia initiated. Here's a P wave there that's different from the sinus P wave. And I see a narrow QRS tachycardia. I see 2 different wide QRS tachycardias, one with left bundle and one with right bundle. And remember what I said, look to the transitions, look to the edges. So I'm going to look here and I'm going to look here. But right away I'm thinking, well, what tachycardia can have both right bundle and left bundle? It's not going to be ventricular tachycardia. There's also a narrow QRS. So, you know, it certainly makes you wonder. So let's have a look. Let's have a look. Describe what you see. Stay away from mechanistic terminology. Look to the transitions. That's what we're going to do. This transition and this transition. The edges, I call them. And cherchez le P. Okay, so what do I see? Well, let's look. I see this tachycardia gets initiated by a P wave that is positive in lead 3 and that is clearly different from sinus. So it's initiated by a PAC. And as the tachycardia continues, I look to the next transition and I see what? The same P wave. The same P wave, a non-sinus P wave. And now when I do my measuring backwards, I can figure out that this, and even this are a P wave. Well, here I actually have the end of a P wave, 2 P waves in a row. So this must be an atrial tachycardia. I look for those P waves. I now map out the rest, and I can actually see them there. Oh, sorry. This is an atrial tachycardia, which manifests itself after pauses as both narrow QRS, right bundle, and left bundle tachycardia. It must be atrial tachycardia. There's nothing else it can be. So it can't be, you know, the AVRT, tachycardia using accessory pathways, could never have 2 P waves in a row because the ventricle's in the circuit, right? AVNRT, AV nodal reentry, can have 2 P waves in a row, rarely, because the ventricle is not in the circuit, but you can't possibly have a positive P wave in lead 2 and 3 in AVNRT because the P wave would have to be coming caudocranially from the AV node up rather than from the top down. So this must be an atrial tachycardia. Okay. So you have to find the P wave and you have to analyze the P wave. It's almost impossible to make a correct rhythm diagnosis without trying to look for the P waves. In both those incredibly difficult ECGs, you had to find the P waves. So you have to learn how to find them. And one of the biggest mistakes I see is that people see lumps and bumps and say they're P waves. Lumps and bumps aren't P waves. P waves are P waves. So sometimes a T wave can look like a lump or a bump. It doesn't make it a P wave. So you have to know what you're looking for. P waves don't always occur in front of QRS complexes. In fact, in complex rhythms, they rarely occur in front of QRS complexes. They may occur during the QRS, in the ST segment, in the T wave, in lots of places. You have to know how to find them. So where to look? They're not always in front of the QRS. Sometimes we see it because we expect to see it. So when there's a T wave of the previous beat, we say, oh, that's a P wave. Well, it isn't a P wave. And there is a way to tell the difference between a P wave and a QRS. Well, think of where a P wave might hide. P waves, a P wave shouldn't be able to hide in a regular isoelectric segment. They shouldn't be able to hide in the ST segment or in the TQRS segment. They can hide during a QRS, and they can try to hide in a T wave. But they can only try because you are now going to be able to find them in a T wave. Unlike most people on Earth, you will now be able to find P waves and T waves. Why? P waves are depolarization. T waves are repolarization. Depolarization, like the QRS complex, is high frequency. It has high frequency components. It has sharp deflections and notches. T waves are rounded and smooth. So when you see something that is high frequency in a T wave, it can only be artifact or depolarization. So now we're going to learn to look, where to look and how to find them. We have to look at the whole ECG. Here's a beautiful ECG where someone thought this was atrial flutter, but it isn't. This is sinus rhythm, because you have to look at all the leads. And when I blow up lead 1, 2, and 3, we can see very nice P waves in lead 2, even though we have all this other artifact, which happens to be a tremor, left arm tremor, Parkinsonian tremor. Okay. We have to know to look for them, not just where to look for them. So when we look here, we see P, QRS, T, but then we see a high frequency deflection at the end of the T wave. Let me blow that up for you. Look at that. See that? That cannot be part of the T wave. That is high frequency. See this? High frequency is not repolarization, it is depolarization, or it's artifact. But I can tell that it can't be artifact here because there's one at the end of every T wave. So this is 2-to-1 block that wouldn't have been recognized easily. Who, when they first saw that, realized that that was sinus rhythm with 2-to-1 block? But now you're going to get it because you're going to look and you're going to see that. And as soon as you see that high frequency deflection, that can only be a P wave. That can never be part of the T wave. Another one. This 32-year-old man would have palpitation when he started exercising or doing anything. Came to the emergency room. They recorded this ECG. He was feeling fine at the time. And they said, well, I don't know what it is. Go home. And you see this P wave halfway in between two QRS complexes. Everyone see that? Halfway in between, a sharp deflection. See how it's pointed? See how it's notched? T waves never have a notch. So when you see a P wave halfway in between, you have to think there's another P wave and it's hiding. Where can it hide? There's only one place it can hide from you, because now you know how to find it in a T wave. The only place it can hide is in the QRS. So you look in the back end of the QRS, and I've blown up lead 2 for you. And here's that P wave which couldn't hide from you. And here's this one, which also can no longer hide from you. So it wasn't sinus rhythm with first degree AV block. It was atrial tachycardia with 2-to-1 conduction. And when he gets active, he goes 1-to-1 and he gets palpitation. When he's lying in bed in the emergency room, they want to kick him out because he's 2-to-1. Okay? This can no longer hide from you because that's the answer right there. And this is what causes you to ask the question. When you see a P wave halfway in between two QRSs, ask, is there another P wave there? You may have to give adenosine, you may have to do carotid sinus massage, or you may just have to look a bit closer at the ECG. The wonder of PowerPoint, the ability to blow things up, makes things much easier to see. Okay. You have to, this isn't a complex ECG, it really goes on the last one. You have to measure the intervals. You have to measure the intervals. You have to look. You can't just look at an ECG and say it's fine, it looks normal. This is a 19-year-old woman who had syncope while running, could have been diving into a pool. By the way, diving into a pool and having collapse, long QT1 or CPVT, catecholaminergic polymorphic ventricular tachycardia, also one of the inherited arrhythmias. CPVT is the other one. So this is a long QT syndrome, and she in fact had a mutation in KCNQ1. It was a potassium channel mutation. You have to just go through you have to have a system. You have to measure the intervals. You have to look for the P waves. Okay, so this one was sent to us as heart block. You get these all the time. So let's just walk through it. PQRST, 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 P, no QRS. What's that? T. So this is artifact. You've got a T wave there. There had to be a QRS there. You see how this is flattened? Somehow the monitor just happened to cut out. Just happened to cut out at the moment right after the P wave. I'll blow this one up for you too. And you can see a normal P wave and a totally normal T wave. So this was sent as heart block. You have to examine things closely. The answer is almost always there, but you have to look. This one, 24-year-old woman with syncope. This was recorded on her monitor. She had a syncopal episode at home. She came into the emergency room. While in the emergency room, they recorded this. She did not have syncope while in the emergency room. This was just recorded, and they called us because she had polymorphic VT. You have to look. So what do we see? PQRST, 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 and then we see junk. Something happens. Well, we see a QRS there, don't we? But clearly there's artifact. So when there's one artifact, when one lead's loose, think that everything's loose. And then what else do we see? Well, we see this right in the middle. And then we see this. What's this? So now you have to look closely. I'll blow it up again for you. And you take your intervals and you measure. And there's our RR intervals based on this. And this fits exactly with twice this, so there's probably a QRS right here. There's certainly one there, we can see it. And so we have a couple of question marks there and there. And those are almost certainly sinus QRSs there. That's all artifact. This patient was referred to us for polymorphic VT just because the doctor didn't actually look at the rhythm strip and look at it carefully. The answer is usually there in front of you. So this was in fact artifact. This was all artifact. She had sinus rhythm during this whole thing. Her syncope was vasovagal, had nothing to do with an arrhythmia. When you see a pause, you have to ask yourself, what's the cause of a pause? Is there a block? Is there sinus node dysfunction? So once again, what do we look for? What's the commonest cause of a pause? Well, where can a P wave hide? Can't hide from us anymore, can it? We're too good at it now. Look at this. Look at this T wave. Look at this T wave. I'll blow it up for you. Sinus P wave, QRST, sinus P wave, QRST. Compare this T wave to this T wave. The T wave before the pause has what? Describe it. It's a high frequency deflection. High frequency. It's got a sharp point. It's got a notch. What can it not be? Can't be part of a T wave. Has to be either a P wave or artifact. Can't be anything else. So I look at before the previous pause and I see the same thing. Artifact is random. P waves are not. So this is a blocked PAC. Not sinus node disease, not SA block, not sinus node dysfunction. This is a blocked PAC. The P waves can no longer hide from us. We just have to know where to look for them. I'm going to do this one as a last one. So this patient comes to emergency, gets put on a monitor at emergency. So what is it? Is it sinus tachycardia? Probably not. The heart rate's 200. SVT or VT. So I look at it and say, well, it's a narrow QRS tachycardia. Take your time. Don't rush into things. I phone them up and say, okay, I'm on my way over. Can you just make sure to do a 12 lead before I get there? There's the 12 lead. A narrow QRS isn't a narrow QRS until you've done a 12 lead. This is the strip they were monitoring. And it looks for all the world like a narrow QRS, and anyone would have said this is SVT. But this is VT. This is VT. It's clearly VT. This is not a narrow QRS. It's a wide, bizarre, abnormal QRS. And in fact, you can actually see the negative P waves with VA Winky back in there, but I won't go into that. So it isn't narrow until you've looked at the 12 leads. So when someone says they've got a rhythm strip and emerge, and they see narrow QRS tachycardia, please say, do a 12-lead ECG. We'll go into this the next day. Lastly, describe what you see. We've said it before. When you make the description, the answer becomes apparent. The atrial rhythm is irregular. It's lumps and bumps and diddles and squiggles, right? So what's the atrial rhythm? Atrial fibrillation. There's no discrete P waves. And when I describe the ventricular rhythm, I've described it as slow and regular. You cannot get a regular output from a completely irregular input. So this is atrial fibrillation with complete heart block. The answer is in the description. Atrial, you identify the atrial rhythm, you say the atria are fibrillating. Doesn't say anything about the AV conduction pattern. The atria are fibrillating, and I have a regular ventricular rhythm. We've seen this a couple of times today. This must be heart block. So that's all I really wanted to say. The key thing is you have to have a system. You have to look at everything. You have to describe what you see before you make your conclusions. You have to know how to look for a P wave and where to look for it. And I think if you do that, rhythms become not only fun, but they also, you'll find that you're much, much better at trying to make diagnosis. So I thank you for your attention.
Thank you, sir. With this, we've come to the end of the pre-conference workshop.